All right, so in this episode, we will be covering norepinephrine, also known as Levophed, and how it is used in an intensive care unit setting. Quick disclaimer, the information provided in this video is for educational and informational purposes only. I'm not providing medical advice, diagnosis, or treatment. Although I am a healthcare professional, this content should not be used as a substitute for professional medical advice from your own healthcare provider. So let's get into it. What is norepinephrine? Norepinephrine is a catecholamine and potent vasopressor. Its mechanism of action is twofold. It works on the alpha-1 adrenergic agonist. This causes vasoconstriction, increasing systemic vascular resistance, also known as SVR, and consequently raising blood pressure. It also works on the beta-1 adrenergic agonists, increasing heart rate and myocardial contractility, although this effect is often less pronounced than the alpha-1 effect. The resulting effects of the two are an increase in blood pressure through vasoconstriction with a secondary effect on cardiac output through enhanced myocardial contractility. So what are some key uses of norepinephrine in the ICU and what's its dosage? So norepinephrine is primarily indicated in different shock states where there is significant vasodilation leading to hypotension, such as in septic and neurogenic shock. It also does, however, have a role in cardiogenic and anaphylactic shock, but this is more selective and usually when there's refractory hypotension. Its potent vasoconstriction properties make it a key tool in stabilizing blood pressure and ensuring adequate organ perfusion across various types of shock. So the dosage for norepinephrine can be both weight-based and non-weight-based. The weight-based dose would be around 0.01 to 0.03 mics per kg per minute. The titration for it is based upon the patient's blood pressure and response and clinical status. So we're typically aiming for a MAP or a mean arterial pressure of around 65 millimeters mercury or higher, depending on the clinical scenario. This is then gradually tapered based on the patient's condition. If he stabilizes, the dose is gradually decreased to avoid sudden drops in blood pressure. So now let's look into administration and monitoring of norepinephrine. So for administration, norepinephrine is typically administered via continuous intravenous infusion through a central venous catheter, and that's due to the risk of extravasation and tissue necrosis if given peripherally. Some symptoms of extravasation include pain, swelling, redness, and a burning sensation around the IV site, and in severe cases, tissue necrosis. Titration for norepinephrine, so usually we start the dose low and titrate based on the patient's blood pressure goals. This can include their mean arterial pressure, or a provider might also choose to use their systolic blood pressure. Monitoring during the administration of norepinephrine is critical. So we're going to want to monitor the patient's hemodynamics. This includes their blood pressure, heart rate, and mean arterial pressure. This can often be done through invasive arterial lines that are often used for accurate and real-time blood pressure measurements. You're also going to want to monitor their urine output to see how their renal perfusion is, as norepinephrine can in fact reduce renal perfusion, and monitor their lactate levels to assess tissue perfusion and effectiveness in reversing shock. So what are side effects and considerations when using norepinephrine? So like stated earlier, extravasation is a risk when using norepinephrine, and it can cause severe tissue necrosis. This is why it's important to use a central line when possible. If extravasation does occur, phentolamine, which is an alpha blocker, can be administered locally to mitigate tissue damage. Peripheral ischemia is also a side effect. High doses can lead to peripheral vasoconstriction, risking ischemia in extremities. And then there's tachyarrhythmias, and although less common than with norepinephrine than with other catecholamines such as epinephrine, make sure you are vigilant for arrhythmias. And then volume status. So we want to ensure adequate intravascular volume status before initiating or increasing norepinephrine, as vasopressors are less effective in hypovolemic patients. So what are some key points to remember about norepinephrine in the ICU? Well, first off, you're going to want to administer this medication through a central line, and this will minimize the risk of extravasation by using a central line venous catheter. You're also going to want to have continuous monitoring for these patients, and that's because given its potent side effects, continuous monitoring is crucial to adjust doses and monitor for side effects. And lastly, some patient-specific considerations. You're going to want to tailor the therapy based on individual patient conditions, such as the presence of arrhythmias, cardiac function, and volume status. And that is all. So thanks for watching, and please feel free to leave a comment about any future ICU medications, devices, or concepts you'd like to learn about in the future.